Thank you. So this is a multidisciplinary clinic. It's a multidisciplinary presentation, and so just speaks to the fact that I'm kind of scared to do anything alone these days. But yeah, perfect. Can you all phone call? Sorry. Yeah, so I'm really pleased to have this opportunity, and just want to make sure that this doesn't somehow come over as a advertising pitch of our center, nor do we want to show off. This is something Anna asked us to do, and I'm hoping that it can be something that actually benefits others. There's also important to mention that some of the stuff that we do is potentially not generalizable to other institutions because of where we are. We have a very unique setup with the the institutional organizational hierarchy and all that allows us to do these things. But it's all on the basis of one man and really one woman. It's the Hugo and Ann Moser who Hugo Moser just there's a lot of younger people in this room, so I'd take maybe 30 seconds to give background. Hugo Moser was an adult neurologist who was trained at Harvard at Mass General Hospital, and was the director of the Eunice Shriver Center for Mental Retardation, which is what it used to be called back then in the 1950s and 60s, and then was recruited to become the president of the so-called Kennedy Institute, John F. Kennedy Institute, in 1977, where he was the president until 1988, and then he retired. And that's really when his research career started, at retirement. And then he basically worked until his last day of life in 2007. And some of us here, Kim and I, had the privilege to work with him for several years. And he was one of the most passionate people anyone will find. And certainly that's also how patients perceived it. And so he really inspired us. And so we called the leukodystrophy program after him. But the bigger issue was that we were trying to see, how do we address the issue that Anna brought up? Yes, especially when we started this as a multidisciplinary clinic. This is back in 2012, so about 13 years ago now. Most leukodystrophies were untreatable other than bone marrow transplant and cord blood transplant for 3 diseases with some variable, outcomes. Maybe the CTX therapy, at least for the adult population at that time. But we again took the approach that we want to improve the care of individuals, regardless of whether there is a cure or not. We can always do something, and so I kind of felt like I was useless as a neurologist alone. I still believed in that. No offense to other neurologists. So we had the opportunity to bring in a big team, and we had our genetic counselor, Julie, who was with me in the neurology clinic together. And she was also in a multidisciplinary clinic for muscular dystrophies at Kennedy Krieger. And that was a great model for us to take on and just basically try to photocopy them. And she knew all the tricks, how to organize those schedules and so on. So we went around, and I think this is one critical thing. If there's one takeaway today, is that we didn't go to the department chairs and say, hey, give me a rehab doctor or give me a physical therapist. We looked for those people. They were the friends, the people that we knew, we trusted, that knew us, and said, hey, do you want to do this together? And I think that's really critical. You want to get them to be excited about the opportunity to work with you. And some of them could join, and so we could build a multi-D. A couple of people could not join because, for example, when an adult neurologist was on the Hopkins side, and Kennedy is complex, but we are a separate institution than Johns Hopkins, even though we are an affiliate. And so I just had to find that right endocrinologist who was willing to partner with us, who was willing to talk to us via email, chat, and so on, so we could actually discuss patients. And so we put together our team, and we became pretty early on, I think, one of the LCN centers. I mean, this is obviously something that Anna already talked about, but that team has grown over the years, and actually, I think 7 or 8 services. So we have currently 4 neurologists. The Dr. Jay Raymond, who left the institute, came back to Hopkins a few years ago. So we're very lucky to have him because he has been in this field for about 30 years. And then, Dr. Fine, whom you're going to hear later today, and Dr. Malik, who you heard already today. And then we have two physical therapists, and very, very importantly, we have all these other specialties. So we have three rehab doctors, pediatric rehab doctors. We have palliative care. We have a rehab physician who is focused on spinal cord injury, and in her role in our clinic is specifically looking at urodynamic studies and doing urodynamic studies in our adult population, because almost all of them have significant urinary issues. We have a pediatric endocrinologist who comes to us on site, and we have two adult endocrinologists on the Hopkins side. We have, of course, our genetic counselor, our social worker. We have two nurses. Kim has been a partner in crime since we were both kids. And has been working in the leukodystrophy field since 2002. Darian joined us more recently and has been doing a fantastic job. And then Lachelle is our nurse practitioner who joined us now 2.5 years ago, almost. Or was it 2 years? Something like that. And all of this is, and then we have our research team. Most critical piece of the team is the person in the center, the coordinator, and having a coordinator is critical, and having a high-level coordinator who has capacity to coordinate these visits and get the right records and interact with the patients is more than what a regular coordinator actually needs. So we actually have a manager, a project manager, Chris, who's here today, who's been coordinating everything, and that's really critical. Otherwise, everything falls apart. And so since this is, again, a multi-D clinic, we're going to have a few more people present. The next person, I'm going to introduce all of you first, but Lachelle, no, you can come. Lachelle, like I said, is our nurse practitioner. She's been basically acting as a proxy for our neurologist. She sees patients together with our neurologist, makes sure that we don't like misbehave in the clinic and say the right things, and actually is extremely critical in having acquired all the skill sets that we need for not just the clinical assessments, but also doing clinical research assessments. So we try to enroll pretty much every patient we can into all our natural history studies, and she has learned all the scales and she can apply all those. Then we're going to have Darian, like I said, one of our nurses present, and then we're going to finish up with Julie Cohen, who's the director of genetic counseling in Kennedy and has been another partner in crime for many years. I hope it's not a crime, actually. So at this point, I'm delighted to shut up and pass it on.
Thank you, Dr. Fatemi, and thank you to everyone here today. So these are our different types of clinics. We have our multi-D clinic, where there's all the disciplines, including myself. So like Dr. Fatemi said, rehab medicine, palliative, and our endocrine provider as well. Then there is a genetics clinic, which our genetic counselor is there and a neurologist sometimes, or it can just be for genetic counseling. We kind of do that as a diagnostic clinic if we can. And then there is the newborn screening clinic, which staffs myself, Dr. Malek, and our pediatric endocrinologist. And how we determine which clinic the patient is staffed in, I'm going to talk about next. So the patient or referring provider will reach out to our clinic coordinator, Chris, or our nursing coordinators to express interest in being seen in the clinic. And then the coordinators will gather all the pertinent documents, including genetic tests, lab values and results, clinic notes, and brain MRI images if they're available. This information is then passed along to the neurology team and our genetic counselor to determine the appropriate scheduling for the patient. To ensure that the appointment is meaningful to the patients, our nurses will call the families prior to the appointment and discuss what their main concerns are, what their goals are for the visit. And then we have access to that information prior to the visit. Now, Darian.
So, as Lachelle and Dr. Fatemi have already kind of said, our clinic is special in that we have all of our multi-D providers available. That full multi-D team meets twice a month, where patients are scheduled with all of the providers that are relevant to their care. During that clinic, we can see up to 8 patients in any day. Once the patients arrive in our clinic, they are scheduled with just one clinic room for the day, and the providers will rotate in and out. We have a designated conference room that our providers will hang out in. Why I'm so nervous, you guys. So they hang out in the conference room and can talk between patients to coordinate their care and make sure that everybody is meeting those care needs. It's mine and Kim's job during that day to keep them on task and rotating back into patient rooms. We also have our research visits available during that time as well. So the providers will see the patients, and then our research teams can come in and complete the research visit or enroll new patients. It's not just me. So things that we do to coordinate care between visits, our patients are typically seen annually, but we can see them more often if they have increased care needs. We provide support with referrals to PT closer to home as needed. For our new patients, follow-up care can also include coordinating visits for affected family members to come in and see our genetic counselor, Julie. We also like to provide patients with brochures for things like Hunter's Hope or ALD Connect. So our goal is really to just provide that well-rounded clinical experience for our patients.
Okay, thank you, Darren. So we also have implemented the Healthy Planet ALD registry with CHOP. And this was implemented in the fall of 2024, and it was developed through some NIH funding. The dashboard tracks all standards of care time points for our ALD and our newborn screening patients, such as brain MRIs, lab values, and their next appointment. So it kind of has everything all in one place so we can see it. From the dashboard, you can see if the patients are in range for their brain MRI, so green is good or on time, yellow is close to the due date, and then red is past due when they should have repeat imaging. This helps with follow-up and decreasing the chance of losing patients to follow-up care. We can send reminders through MyChart messages for these patients, and if they don't have access to MyChart, some people don't, unfortunately, then we can send like a letter via mail. We haven't used that at Kennedy yet, but we plan to in the future. The dashboard also shows the lab values, as I was mentioning, for like ACTH and cortisol, which is helpful to determine if our endocrine provider should be a part of the next visit or if they need to have some recommended labs completed. In the future, we would like to see the dashboard sort patients specific to the providers and maybe have some alerts as well. Lastly, one of the features I like to highlight for Healthy Planet is that we can extract de-identified data for natural history studies. So that's also a big deal. Okay.
I'm back. Yeah, so just briefly talking about research recruitment, we're trying our best to try to literally enroll every patient with the leukodystrophy in a research study. I think we have around 23 IRB protocols. Until a couple of years ago, I was the PI for all of them, and I was about to commit suicide. Luckily, we now have a bunch of other people who took over as PIs, so which is great. But we essentially have natural history studies primarily for adrenal leukodystrophy and for LBSL. They include outcome measure assessments. Some of them are remote outcome measure assessments that Amina will talk about later this afternoon. They're also one of the GLIA sites, and so we're trying to enroll all our patients into the GLIA projects. There's one of the projects in particular to enroll all leukodystrophies in and capture data and biospecimen from them. And I can tell you this is a struggle. So we've been doing this for years and years, and we have all these resources. We have a full-time coordinator. We have 3 clinical research coordinators, and we're probably missing still about half of the patients. And it needs a lot of coordination and persistence. So we have, for example, found out that, one way of communication to families wasn't sufficient. When we just send email, say, how are you interested? They kind of like, oh, okay, well, we're going to talk about this. Then when they come, once they're in the clinic, we are busy because we're doing our clinical stuff. So there isn't really time for us to like come up and have these research conversations. And on the other hand, we have also done the other experience where we had at some point, like coordinators call every single patient before the appointment and say, would you like to participate in research? And then we hit a barrier, especially for those first evaluations, because some of these kids were coming, we were just going to tell them you have Alexander's disease, right? Or they were just diagnosed with Alexander's disease or some other really bad diagnosis. And parents are in shock, and they weren't really ready to hear that as a first statement from a coordinator on the phone before they even see how we look like. And so it's difficult to get that going. And so we've had a balance back and forth trying to change our strategies. First start off with an email. If they don't respond, maybe a gentle touch, and then also be a lot more aggressive on those patients who are already established in our network rather than those that are coming first from the outside. And then it also requires coordination with our basic researchers. For example, many of the biospecimen collection protocols require that you centrifuge the blood sample quickly. And so, if you do a blood draw at 5 p.m., those folks have to be waiting in the lab and may have to stick around, especially if it's like for iPSC derivation until like 8 or 9 p.m. at that night. And so it's not ideal. So there are some logistical issues that come with it. So that's also, of course, there as a platform to try to recruit patients for clinical trials. And I imagine everybody else is doing great there as well. We got to finish up by just talking about some recent efforts we've had to try to automate the scheduling system. Lachelle mentioned, we basically have 4 types of visits within this center, the multi-D, the diagnostic, the newborn screening, the genetic counseling. And so this has been really an effort by Julie and Chris and the EPIC team. And so Julie's going to finish that up.
Thanks. So when Dr. Fatemi approached me and Chris to say we want to create automated self-scheduling in EPIC, I told him, I said, this is definitely not going to work. And I pushed back several times. I said, well, maybe we'll start with a simpler clinic. But it turns out he was right that, that we think this is going to work. So the idea with automated scheduling is that new patients who've never been seen at the Institute will be able, via MyChart, to schedule their own appointments with us. And I'll explain the tree that we did, we also wanted to balance, one, the ability and the efficiency of self-scheduling, but also making sure it was appropriate and making sure that if there were unclear situations or urgent scenarios, that they weren't going to get stuck in some, lost in the system, that we want to be able to bring them in as soon as possible. So bringing this slide up again about our different visits. So the first step to do this, develop automated scheduling, is we really took a step back and said, what kind of patients come to our clinic? Can we bucket them? And how do we kind of intuitively decide what clinic they should go into? And it was a really good exercise, and we were able to bucket this. So we identified that, well, who goes in our multi-D clinic? These are people with known and confirmed leukodystrophies who are symptomatic. Who is going to be in the newborn screening clinic? That's easy, of course. Babies identified in newborn screening, or asymptomatic or pre-symptomatic children. We recognized that there were some scenarios where a patient didn't need the full team, who just needed to see neurologist and genetic counseling. Maybe it's because they don't have an established diagnosis, or maybe it's an adult who is pre-symptomatic, say someone with ALSP, and it's not just genetics, they need more than counseling, they need a physician who's going to follow them over time and order any screening. And then some patients who really just need to meet with me for genetic counseling. So this process for Chris, Dr. Fatemi and I involved lots of whiteboards where we were like drawing boxes and really trying to make sense of it. And we ended up, after a while, kind of making sense of it. So I don't want you to read every word on this screen, but I'm showing this as a flow chart. So we also, after we bucketed patients, after we figured out where we wanted patients to end up, we then said, well, what questions or pieces of information do we need to know to get them there? So some things come right from EPIC, the biologic sex and the age, children or adults. We, of course, needed to know if they had a confirmed leukodystrophy diagnosis, or if they didn't have a confirmed diagnosis. We needed to know if they're symptomatic or not. And in some situations, we needed to know like what their goal was. So again, without reading every word on here, you can see it works in a flow. Known diagnosis or not, symptomatic or not, age, biologic sex. So this took a while for us to map it out, and then we met with the EPIC people. And they did their magic, which I didn't put that slide on here because that's even smaller print. But they took I shouldn't say C Breezy over there, Chris's PowerPoint skills to put together this flow chart and put it into whatever EPIC wizardry they have. And so that's been created now. And we're at the point. Again, please don't read every word on this slide. This is a slide from our EPIC team, kind of the overall flow. I described to you that pre-work that we did to scope and map it with the EPIC folks. They built that decision tree in EPIC. And now we're in the part where we're manually validating it, where when Chris is getting a new referral, he is himself working through the flow chart or the decision tree in EPIC to see if it lands where we wanted it to land. And then there's, in the go live, those would be those next steps where patients are going to be doing it themselves. I just did a lot of talking. So what are the things I didn't mention? So I didn't mention how we flag patients for that urgent review. So if there's certain diagnoses that they answer, they'll get a message that says, okay, please call our clinic. For patients who don't have a known diagnosis, they can't self-schedule. So for those, we want to review, it's not urgent, but we want to review those records before determining if they're appropriate at all for our clinic and where in that clinic. So it's pretty cool. It turns out he was right, at least in theory, that we can do this. You'll have to stay tuned to see how well it works. And I'm sure there's going to be lots of bumps along the way that we'll need to work out. In summary, so our team also, in preparing for this talk, like Dr. Fatemi said, this isn't an advertisement for what we do. We think we do it pretty well, but we are not complete. We are still a work in progress, but we looked back over the last 10 years and thought, well, what are the things that helped us get to this point? And just to summarize some things we've already touched on about the importance of having dedicated clinic coordinator to do scheduling and communication with patients, our dedicated nurse clinicians, like Dr. Fatemi said about that relationship building. And so we're super lucky that we have rehab and other specialists who come into our clinic. We acknowledge that at a lot of hospitals, that's not going to be possible. And that's okay. So maybe a second best is, instead of just referring to rehab somewhere, having identified in advance a rehab doctor or two who is interested in being with your population, and then you refer specifically to that individual. There's some other IT related things, like the ability to have multidisciplinary encounters in EPIC or the electronic medical record of your choice. Institutional buy-in, we can talk more about that. Again, we acknowledge that some of the reason we can do what we do is because of the uniqueness of our place. And then everyone's best friend and worst enemy, prior authorization. So I think I'm going to stop there with our slides so that we can hear from all of you, the questions you have. We want to hear about things that have worked for your clinic as well as things that are challenges, and maybe we can talk through that. And I'm going to invite, I don't know if our other doctors want to come up. Certainly Seabreezy, Chris Bramble should come up because there might be questions for him.
All right, thank you. Round of applause for our KKI team. And Dr. Kurtzberg and Chris is going to come up. Dr. Kurtzberg is going to lead a discussion with the group to think about these great points.
Yes, so thank you all. This was amazing. This is sort of like the wish list of what a multidisciplinary clinic, I guess, could be and should be. But I think, and I'm going to take questions for you all in a sec, but I just want to say, I think some of us in a little bit more of the real world struggle with how to put these kinds of resources together in a more traditional academic setting. But let's start with questions from the prior presentation.
Hi, this is Nikki from Rochester. I remember being at ALD Connect 2 years ago and listening to Dr. Dang's talk on following the ALD maintenance and being blown away by the ability of Epic. And so it's nice to hear that another institution has picked that up. And so can any of you guys speak to kind of how other institutions may work with their Epic teams to build that in? Is that widely available? Does it have to be built? Can you talk about how that transitioned work?
So yeah, so I worked with Laura on this, and the first piece of it was identifying the Epic people at our institution who can sort of do this. And I was just making a comment back there. Coming from a really large hospital and joining KKI, you know, something specific up to KKI is it's a small community, so that person was semi-easily identifiable. If you're coming from somewhere like Pennsylvania Hospital or New York Presbyterian, it can be a little more challenging to really get somebody who's invested. And then you sort of connect that person with, we connected with the Epic person at CHOP, and they sort of shared, you know, the backroom programming that kind of goes into building the dashboard. When they were doing that, you know, sort of I sat in, and I think Lachelle sat in on some of those meetings. And then once they built it out at KKI, then we went through a couple of rounds of sort of modifying it and fine tuning it to fit our purpose, right? So we wanted certain variables in there that we thought made sense just based on the frequency by which we follow patients up. And then the color coding that went into it really kind of was reflective of the age-specific sort of guidelines, and also what was taken into account was how long it actually takes to schedule patients. So, you know, when you see the patients in red, they're kind of like within 2 months of needing that thing. So it's not only that they've passed their deadline, it's actually they're within the scheduling window that's going to put them past their deadline. So, you know, that took it was like it was an iterative process. And now that we've launched it, there's like a new set of things that we want to sort of build in. So doing it by provider, we talked about having patients' genotypes potentially entered in there. And you can kind of see over time that this really useful clinical tool also facilitates doing, at the very least, retrospective research and data mining for your population. So yeah, hopefully that answers your question.
If I could extend that question, I think maybe there's a thought of, would you share that? In other words, would your Epic people share the construction, the configuration with other centers so it could jumpstart at other centers? I know at my center, when we want something from Epic, we're at the bottom of the list, no matter what happened. And then we get kicked off, then we have to go back. So if there's some pre-work, it helps.
Right, right, right. Because every institution has a different instance that's of Epic that is fine-tuned to that institution, right? At the institutional level, like no two Epic systems look the same. Now, the way we did it was under a grant mechanism, right? And part of successful execution of the grant on the CHOP side was to demonstrate feasibility of implementation at a separate site. So there was also obviously funding and time that came with that. So there may need to be some financial support to have some Epic person say, dedicate 10% of their time for a year to sort of build something like this out. Yeah.
You've got one right here.
Oh,
Can I go next? Okay. Hi, Matt Ginsberg from Akron Children's Hospital. I have a question just about from the operational side. For those different clinic visits, are they all just kind of running in parallel to each other? Or do you have sort of dedicated blocks of time for the GC plus neuro and the multi-D and the newborn screening, to help maximize utilization and not everybody just sitting around if they don't need, just-
Yes, thank you for asking that. Our multi-D clinic is on only one day, well, 2 days a month, but there's one day. The multi-D clinic is itself. The genetic counseling only visits are actually mostly telehealth that are done separately according to my schedule. Our newborn screening clinic is also a designated day that's separate from the multi-D clinic. And then the neurologist plus GC, sometimes that will be in a multi-D day if there's the appropriate slots, or it might be on a different day with Dr. Fine's clinic or Dr. Malak's clinic. But also to your point of just about like sitting around, that's a challenge with multi-D clinics in general, is that you have a whole bunch of providers that are just chilling in the conference room, and maybe it's a circuits, who's going to see what when. Something else that our clinic coordinator does is that provider, you saw on the schedule slide that different disciplines have specific times for each patient. And so there may be days where, just for example, only 2 of the patients need to meet with me. Well, I know when that is, so that other time I can be doing something else and I don't need to be hanging out in clinic. That takes coordination. That is a lot of the pre-clinic work of looking at the records, of speaking to the patients, what our nurses do. So fitting people into slots.
yeah. For the most part, it's kind of like a carousel, right? So like it's just there's 3 or 4 time slots, and I'm slotted out to see all 4 patients or all 3 patients, with 90 minutes each, which is also very specific and kind of a luxury having that much time. Like an 8, a 9:30, and 11, I'm seeing patient A, B, and C, while the rehab doctors in those same time slots are seeing B, C, A, and then the genetic counselor is doing C, C, A, B. So it's just kind of this like carousel sort of movement. And Darian just comes into the room when we're going too long, and she pulls us by the coat out of the room and pushes us into the next one. And that's just kind of how it goes.
Yeah, because that sounds like a lot and very complex, and it is. Thankfully, we have Chris to to think through all of that for us. But just from a provider's perspective, it's pretty simple. It's like, I know that I'm going to see, 2 to 3 patients on. It's always Tuesday morning, like 8 and 9:30. It's always a discussion if that has to change for any reason, but it's like a very consistent schedule for the providers. And then the other benefit of that extended 90-minute slot, sometimes we certainly run over, but people like Darian help keep us on track and give us reminders. And there's actually a big whiteboard that's live during the conference room, where we can kind of see when people came into the room, when they came out. And the 90 minutes gives us, 10 minutes or so to like discuss the patient. So I come out as the neurologist, and I'm always talking to PT and rehab about my impressions. And so it's a handoff. That's built in as well. And then from the patient's perspective, especially, they have a schedule of who they're going to see. They get that in advance. It's another layer with research, but then our research coordinators like have a nice color block schedule where they can easily see like when they're going to see the providers, when they have lunch, when they're going to do certain research assessments. Oh, yeah.
Oh, I just wanted to follow up on the Healthy Planets. Just email me. I share it with everyone who wants it for free. I don't have funding for you to implement it at your site, but because it's a clinical tool, honestly, most Epic teams put you in the queue and then they just implement it. And in fact, it's now live. Mark England's group has it in Europe too for ALD monitoring. They adapted it much more for the adult ones, but it's just like, it's a compliance registry. We're going to build it for all the leukodystrophy newborn screening ones. So Krabbe and MLD are next on our docket. And we have a clinical one for AGS too, just because the multisystemic complexity of tracking children with AGS to make sure they're compliant. So, I mean, it's ways to alleviate burden and potentially not miss something that's catastrophic. I will say the added benefit is when a child is first diagnosed with a disease through newborn screening, there's oftentimes a handoff of care of they get referred into metabolism and then they go to neurology. There have been a small number of cases where the family has been so scared and they haven't scheduled with us, and I've caught it through Healthy Planets, right? Because I know that they got diagnosed because they have, right? They got flagged by the system. So Healthy Planets is a really great way to make sure we are holding families' hands all the way through the process, including those really vulnerable handoff positions. And I never would have known those kids existed if I hadn't had a tracker have them pop up. Me go, oh, hello, 1 month old. I haven't met you yet. And so I think it's a really great time savings tool, but honestly, a safety tool too.
Yeah, just a logistical question, since you have the luxury of having 3 child neurologists on your team. How do you decide on who, does everybody see the same patients, or is it some patients, some physicians, some providers will see only some, or how did you figure that out?
I can just answer quickly that for the most part, the doctors will see all diagnoses. For some diagnoses, like if there's a patient with LBSL, so Dr. Fine will see that patient because that's her jam. Yeah.
So I think this makes all of us want to come work at Kennedy Krieger. I will just say one thing about the Healthy Planet. We tried very hard to get it at MGH. It's a no. So I don't know what it is in the higher ups, but I just think some of this stuff sounds fabulous and there can be clear barriers. And so I think it's important just to recognize that, and so families also recognize that, so we have a lovely Excel sheet that has pink instead of red, but is not as good, and it's riskier. But my actual question was, how do you balance that schedule with the clinic research patients? Because one problem we have had is that there's these time sensitivities once you're giving drugs. And so it's been very challenging to be booking out for routine clinical appointments and then have to have these very time sensitive dates and fitting that in.
To really coordinate the research and clinic visits, and pretty much continue this conversation with our research coordinators. For some of the research protocols, they have remote visits every 6 months, but they may only come to see us once a year for clinic, and they'll have their in-person research visit then. So they'll email me right when they get off the visit. Hey, I just met with this patient. They're coming in. They need to come in this time. Please work with them to get a clinic visit. And if for some reason, like I can't get it the specific day or month they need, sometimes there's, a month or 2 variance that's fine. And I always check with them for that. Same thing on my end. If I schedule somebody that they tell me would be a good candidate for a certain thing like calyx or something, and they need a screening MRI when they come in, then I schedule them and reach out to the research coordinator and be like, hey, I have this person coming in, we need to get an MRI for them. Can you schedule that at our MRI center? So it's really just a constant communication between me and the research coordinators. And I also sit in on the research meetings biweekly now as well. So that way I kind of know what's going on that end. And then we put the clinic schedule up, the upcoming clinic schedule up, so that if they have any questions for me, I can answer them then too.
So, I mean, if you're thinking about a clinical trial, right? You know, and you have these patients coming in, you know, every 3 months or even earlier, or every couple of days, right? So, there are sort of the depending on how it's structured, there is the one-off piece, right? So there are just some days where, yeah, like, you know, for like an interventional trial, and a patient has to come in for calyx or you know, someone's on lariglitazone, they have to come in for their labs. Sometimes it's just, it's like, hey, Chris, we got to get this guy in. What? Yeah, and so those visits will happen outside of our normal schedule. It'll just sort of be a one-off. They'll get them into clinic, and then one of us will just have to be there that day. That's just the practicality of it.
So I think
Yeah.
this is also something that Hunter's Hope maybe can help, because once you have more volume
Mhm.
of clinical trials where, and I'm sure Dr. Kurtzberg runs into where you're seeing them like multiple times a week, that becomes really challenging. And when it's not just a, you know, that's, Amanda could speak to it more. That's been a big challenge for us, because if you're going to do an AV therapy, now all of a sudden it's not monthly, it's multiple times in a week. And also there's a different level of urgency. So you can't, you don't have like 3 months to figure out where to put them.
Talking about clinical templates for research trials, that's just outside. So like, you know, we might have Tuesday multi-D clinic, but then for the trial patients, they're coming on a Wednesday or Thursday, or maybe Wednesday and Thursday. It's not, yeah, that's certainly, that's why you need to have protected time for that research, for that.
And I do want to say Chris and the team is really good at, if a patient has to come in and the physician's only needed for X thing, and then the rest of the assessments can be done by someone else on the research team, like we'll fit them into the schedule. I'll come and see them in the clinic room, do an exam. Lachelle will do like the EDSS. But then if the rest of the stuff is being done by one of our research coordinators, they can take that patient off to the side while clinic is still running, and do the rest of those assessments. So sometimes there is overlap and we just kind of divide and conquer.
I just back to Katie's question, at Duke, we're running all this through the transplant program, which we don't have the luxury of what you have, but in the transplant program, we have a 7-day-a-week clinic, an infusion clinic, people in our clinic every day. So we leverage them like for a gene therapy patient or whatever, so that we can do these more frequent visits, and we don't draw a line between what kind of patient it is. That's just a different solution because we have a different setup.
Just wanted to add also, in addition to the Moser Center resources, we have, I guess, really in the last year to year and a half been, you know, some of our operations are more directly supported by our clinical trials unit at Kennedy. And so that's sort of like an emerging thing that's happening across different clinics and groups, especially in neurogenetics. So, you know, a lot of our coordinators have a training pathway through the CTU as well, and there's essentially a backup or an on-call system. So it does allow like more hands, right, and more infrastructure and spaces if we are anticipating volume that, you know, is difficult to handle.
Hi, this is Kim. I just wanted to make a comment from a nursing perspective. So 22 years at Kennedy Krieger, one of the things that I value a lot is being able to talk to the families on the phone. And a lot of times we're the initial call. Parents tell me that, you know, they've been given this diagnosis, they don't know much about it. They haven't gotten anybody on the phone that they can talk to. And so they're thankful when they can talk to somebody who says, oh, I know about that, I can help you. So making that initial connection, I think, is so important. And it helps us spend time with the family to learn about their child or learn about the patient, what the symptoms are, what their goals are, so that we can better plan the visit around what their needs are. And I think, you know, given that it's a busy, chaotic, multi-D day for them, they're getting a lot of information they're seeing a lot of different people, that they have some comfort in knowing in advance what that looks like, and who the people are. So I think, again, that's a valuable thing, that initial contact and the impression we make.
Thank you.
Sort of an observation, but a question. My take home from your struggle is that you need organization, more organization, and a lot of resources to make a multi-D clinic work. One of the things that we've run into is that as the number of specialists increase, so whether it's a craniofacial clinic or a neurodevelopmental clinic, do you guys ever meet to discuss the patients? I know there was like a handoff where you get 10 minutes, but that's kind of like in the hallway kind of thing. But I mean, an organized thing, because some people's view of a multidisciplinary clinic is that it's more important to have like an umbrella. So you have all the people that need to see the kids, and it may not be on a multi-D day. I mean, I've talked to people at CHOP about their craniofacial clinic, and they sort of limit the patients to one or like two, maybe three specialists in one day because it's just too overwhelming for the patients, basically. So I was just curious what your thoughts were.
I'm always not shy about talking. I'll just answer questions, even if it's out of my domain, but I think I can answer this one. So yeah, so you're talking about like a pre-clinic conference or a meeting where you talk about all the upcoming patients. We had toyed around with that and tried that in the past. And we found that it wasn't, that we're able to, because of these emails that come out in advance from our nurses about the patients who are coming into clinic, the summaries and their concerns, between that and talking like on the day of clinic, either before or in between, we found that works for us. But acknowledge that that there can be benefits to doing more of a formal. Oh, okay.
Yeah, and that does continue, not in a formal sense, right? But just with Epic and the MyChart messaging system. Now I don't know the messages come to me. I'm not sure about what's behind that exactly, right? But typically if there's a concern from a patient, they see me, neurology, and they see the rehab physician. The message will come to both of us so we can, so we're both aware of the issue, and we usually either have an email or phone conversation about how to best respond and who's best to respond. So a lot of that happens in the background continuously. I don't know if you have any other.
Maybe Kim or Darian could talk about the after visit summary, the sort of composite sort of plan.
Yeah, so we do encourage most of the families to sign up for Epic because that's the best way to communicate with us. But once all the providers sign their note, the after visit summary is provided to them in Epic, and has all the recommendations for the follow-up, any follow-up that's needed. And
So-
phone numbers, resources, websites.
But the key part of that is it's a composite list of the recommendations. So it'll say, no, you saw neurology today. Here are the things that we're going to do next. Rehab medicine, here are the things we're going to do next. The families see that, but also our team sees it. And so then going forward, all the parties who have seen the patient and who know about the patient see those recommendations going forward. And that sort of kind of keeps the case and the plan for the case centralized between the whole team. But we don't have like a formalized post meeting where we go, we all saw this patient. What do we think? It's just sort of a composite plan, and then it just gets executed every 3 to 6 months.
To Katie's point, I think the point you were making, which applies to a lot of things, that as we continue to grow and as we have new clinical trials, we may need to adapt things. And one of those, it could be that having a formal post clinic is necessary and is helpful.
So I have there's one. You go. Then I'll.
Hi, Jen from Philly. Coming from the adult perspective, how does everyone get insurance approval to come see you, and how do you address that?
So the insurance can be tricky a lot of times. We get a lot of out-of-state patients, a lot of people with out-of-state Medicaid. which we don't accept any out of state. So most of the time what I try and do with those is get a single case agreement, which majority of the time works, but then obviously you have to schedule them out a little farther and stuff. If we don't get a single case agreement approved, then some patients, we can encourage them to sign up for the financial assistance, and then they can get help that way. And most time, if they have Medicaid, it's free for them. But normally, I always try and go to a single case agreement first before we go that route, and then also we try and screen that ahead of time. Like I know Julie now requests that I put the state and insurance in when I send, just my normal email after I talk to somebody, get the records, put what insurance it is. So we can kind of screen that ahead of time. So we know if that would be an issue, then maybe we could recommend a center that might be closer to them, or if there is one in their state that might be better for insurance wise. Now, some people, if they just want to pay out of pocket as well, we'll tell them, hey, insurance doesn't cover this. You can pay out of pocket, or, so it all kind of depends. But a lot of times when I'm able to get single case agreements, now a lot of people, like our insurance team, probably hates me because I'm always emailing them and stuff and asking them. But that's normally the route that I try and go, and is successful most of the time.
To add,
Yeah, so when we submit those, I give them all the CPT codes for everybody that they'll see. I know sometimes, like genetic counseling, we just had somebody that it wasn't covered, but we were able to get it approved for their follow-up. So it is kind of tricky sometimes, especially because then if you schedule it for neurology, rehab, PT and stuff, but then when they're there, they want to see social work or something like that, then you may not have the approval for that visit, but you can always, when they come back, then add that on. So that can be a little bit of a challenge if you add something the day of that you weren't able to get approval for originally.
I would just want to highlight, I think you maybe asked it also, or a different way you were asking is, in the majority of cases, we do get insurance approval. And we are also fortunate to have a dedicated insurance clearance department where, like Chris said about providing CPT codes. So that department will clear benefits and obtain authorization if needed for all possible services. And that way, whoever they end up seeing, they would be able to see them.
So since you asked about, or since you're an adult talk, I'm going to end with a more broad question. So in the last few weeks, I've heard about 2 adult patients who came from families with distant histories of younger people with either a leukodystrophy or a Krabbe. And then there's an older person in their 50s with symptoms that make you think they could have adult onset leukodystrophy, and they absolutely cannot get somewhere that they can be, even their blood drawn to be tested. I mean, there are a lot of people out there floundering and not knowing. I'm sure Hunter's Hope hears about many people like this. So I'm just challenging everyone to say, we really don't have a way for these people to quickly get seen, tested, and then based on what you find, dispersed to the appropriate medical care.
www.findageneticcounselor.com. If they have a family history of a known genetic condition, reach out to any of our centers, but send the families there to find someone. That's the National Society of Genetic Counselors, not my personal website.
And it really works?
Yeah. It's the National Society of Genetic Counselors registry, where to find a genetic counselor locally or by telehealth. And there are so I have this issue as well with patients, particularly older patients, because Medicare does not recognize genetic counselors as healthcare providers. By the way, there's a thing you can sign on to try to get that bill passed, support it. So older patients can't see me, but there are telehealth companies that provide genetic counseling, and it's at a lower self-pay rate. So it's like $150 or $200 to meet with a genetic counselor. So it makes it a little bit more feasible.
Okay, great. Thank you. All right. Well, we're 1 minute out from lunch. And I think we could probably go on all day, but we're not going to do that. So thank you all. And thank you, KKI team. You're amazing.